Right, and I'm going to be very frank about what I'm going to present. Dr. Sveita asked me to present something related to pediatric surgical oncology and what we do in management of such cases. And I thought the best thing would be to talk about abdominal rhabdomyosarcoma in children. And I just want to tell you, I'm going to reiterate it later on, the importance of having a teamwork with the radiotherapist, the pediatric oncologist, and the pediatric surgeon who's not a general pediatric surgeon, who should be well-versed as a surgical oncologist in a way, to be able to do these procedures. Not somebody who does, say, Hirschsprung disease to go ahead and do a major laparotomy for a child, because then I think the results will not be as good. Introduction about pediatric rhabdomyosarcoma. As you probably all know, it compromises 5% of all childhood cancers, and it's the third most common pediatric extracranial tumor. هلا بطلوا يحسبوا lymphomas والleukemias, they are separate entities. Now, so you talk about neuroblastoma, Wilms tumor, and so on. In essence, I'm sure all of you know that rhabdomyosarcoma has two histologic subtypes, embryonal and alveolar. The embryonal constitutes around 2/3 of the cases. The alveolar is 1/3 of the cases. I'm sure Dr. Ahmad knows that these cases are sporadic, but at times they have associated familial syndromes, pediatric rhabdomyosarcomas. They can be associated with Lifromani syndrome, neurofibromatosis, Noonan syndrome, and so on. I'm not the expert in these, but yes, there is a genetic and familial syndrome associated with it. The tumor biology of pediatric rhabdomyosarcoma, abdominal rhabdomyosarcoma, it of course arises from pluripotent mesenchymal cells with disrupted cell growth and differentiation. Our pediatric pathologists, of course, keep on telling us about the stains used in rhabdomyosarcoma: desmin, myogenin, MyoD1, muscle-specific actin. So the diagnosis is really very well documented with us. Of course, there's also causal relationships for the MET proto-oncogen, macrophage migratory inhibitor factor, and P53 in the oncogenic transformation and tumor progression. Of course, there are histological subtypes to either the embryonal and the rhabdomyosarcoma and the alveolar. Just a quick brief history about management of rhabdomyosarcomas in children. In the 1950s, the cornerstone was surgical resection with not very good results. Then they started using in 1960s chemotherapy, single agent chemotherapies. Again, they did not have really impact on survival. The most important breakthrough in the chemotherapy there occurred in around 1975 from MD Anderson, the famous VAC protocol. Again, I'm a pediatric surgeon, I'm not going to talk about that. But there is, of course, proof, and there are various intergroup rhabdomyosarcoma study groups. Now I think they have reached from 1 to 4 now in study group 5, and the survival is increasing slowly but definitely. Again, I'm not going to talk about risk stratification. Every patient, of course, histology has an important element in it: clinical grouping, the location of the tumor, the size of the tumor, the age of the patient, nodal status, fusion status, metastatic disease. You cannot do surgery for rhabdomyosarcoma without knowing the classification. Again, the staging, anatomy is very important, and as such, we do stage it as 4 stages. I hope all of them were stage 1. Stage 1 is when you have a localized disease and you completely resect it. Yani R0 resection, no regional lymph node involvement, and zero and no microscopic disease. Stage 2 is when you have gross total resection, but you have microscopic disease. It could be either as a residual microscopic or in the lymph nodes. Stage 3, and the more you go down the staging, the worse is the prognosis. Let's agree on that. Especially in this very aggressive tumor. Rhabdomyosarcoma is a very aggressive tumor in a child. In stage 3, it's localized disease, there's incomplete resection, and there is gross residual disease remaining, and that gives it really not a very good outcome. Stage 4 is metastatic disease at the onset. Again, I'm not going to go through the revised risk stratification, except that you should all know that the risk group goes also parallel with the staging, the clinical group, the age, fusion status, and there are so many COG studies going on, and the chemotherapeutic agents used. Just, and I'm talking as a pediatric surgeon, just for we to get acquainted with what COG trials in intermediate and high risk groups have amended recently the chemotherapy, including vinorelbine and oral cyclophosphamide, as a maintenance therapy at the end of standard treatment, because it resulted in definite improvement in event-free survival and so on. So one has got to keep up the pace with the management of those cases. All right. Now, what do we talk about when we talk about surgery? What does a pediatric oncological surgeon do? And there are 4 categories. Primary excision, I wish they were all completely excised, you're happy, there is no further surgical treatment. Some of them come with a biopsy, and then you go after another primary re-excision. That's before. The first 2 are before chemotherapy. And this is what we call primary excision. Delayed primary excision is the case I'm going to typify or exemplify in my presentation to you, whereby you have a large tumor, you have to give chemotherapy, you biopsy, you have got to give chemotherapy for 12 weeks or so, and then if you are able to resect the tumor to an R1 resection, no macroscopic disease, then that would be the most ideal thing. If you want to say, okay, I will biopsy, I will debulk it, and then give chemotherapy, and then give radiotherapy, and then resect the residual tumor later on, to me, I think you have lost the game. So it's very important to identify what to do. Radiotherapy, I wish Dr. Tawfiq Eid was here. Of course, radiotherapy in rhabdomyosarcoma is very important. In essence, there's no benefit for hyperfractionation of the dose, I mean giving the radiotherapy twice daily. There has been a benefit of delayed primary excision in the fact that the radiotherapy dose can be reduced. And this is well tabulated in the statistics. Is there any benefit of early radiotherapy? Suppose you come and take a biopsy and give chemotherapy, and some surgeon is knife hungry at 1 month after, say, 4 weeks, and he comes and charges in to do the surgery. This is wrong. You have to, there is no benefit in operating or in giving radiotherapy at 4 weeks during the chemotherapy. Wait till the end of the chemotherapy, and then surgery, and then radiotherapy. This is what I wanted really to share with you. This lovely 10-year-old female now, who is Lebanese. She came from Sierra Leone with her parents. Her history was that she had colic abdominal pain, 1 month duration, and a huge abdominal mass. It was actually, the abdominal mass was abdominopelvic, reaching all the way to above the umbilicus. The CT scan showed a large heterogeneous mass, 16 by 10 centimeters, and with bilateral hydronephrosis. I want to show you the mass that this patient presented with. And when you check on what vessels go through it. The left internal iliac artery was going through this mass. And notice it's a huge mass, hard, not necrotic, hard mass that this patient had. Again, to cut a long story short, the first thing I did was they asked me to do a mini laparotomy, take a biopsy, and that showed embryonal rhabdomyosarcoma. And so this is what, and it was double checked for Desmond and Myogen and MyoD1. So patient was started on chemotherapy, completed her chemotherapy cycles, 4 complete cycles. Now, to be frank about it, after the 4 cycles, the abdominal mass did not disappear as one would have wished. It went down by about 40% only. It did not reach now to the subcostal margin, but it remained to the level of the umbilicus all the way down. This is my incision here that I previously did. I am showing you these films just to let you appreciate what we've done. So they asked me to go and resect this tumor. I'm just going to tell you, in essence, this tumor was completely resected. It took about 4.5 hours. I had to ligate the left internal iliac artery completely, leaving of course, the external iliac artery there. It is not a procedure to be undermined or belittled. It's not a joke when you operate on like that. And then let me go back. The resection, it was actually arising from the left iliacus muscle. And the sacrum was completely dissected, the periosteum of it, and all those associated lymph nodes were removed. Patient had left hydronephrosis, and look at the ureter after I resected the tumor, full of lymphatic metastatic sites. Again, I skeletalized it completely. When I left that patient, left the operating room, there was no macroscopic disease. It was an R1 resection in such a huge mass. So what to do next? This is the time the pathology showed 40% necrosis only, and the lymph nodes also were partly positive. So, of course, I asked Dr. Toufi in our tumor board meetings, please, Toufi, I'm not an expert, but I want you to give the maximum amount of radiotherapy for this patient. So you give the radiotherapy at that time. You do not continue chemotherapy and wait for it to recur and then attack it with radiotherapy. This is a great mistake. So the usual dose was 41.4 grays. I'm sure Dr. Mu'ad remembers. This is a joint patient of ours, very dear to our hearts. And after several arguments with Toufi Eid, he agreed to add an additional 9 gray. And this patient took a maximal radiotherapy amount on the pelvis. Of course, there was microscopic disease left behind, but there was no gross disease. Even the ureter was skeletalized completely. He begged me, he told me, look, doctor, this patient might develop colitis, she might have, be careful. I told him, to hell with colitis. We can manage anything. If the colon goes necrotic, we can handle it. The most important thing is to target for a cure. I mean, that's the essence of my talk. So troubles arose. The patient, after the radiotherapy sessions, had some abdominal pain, diarrhea, diagnosed to have initial radiation colitis, was given steroids in one admission. Then one day in the St. Jude outpatient, I was called from operating room. She had an acute rigid abdomen, fecal material in the peritoneal cavity, and within 15 minutes we rushed her to surgery, whereby the necrotic rectum and rectal sigmoid was removed. The mid-rectum was closed as a rectal pouch, and a distal descending colostomy was done. Patient was taken to PQ, stabilized. Ultimately, she underwent takedown of the colostomy 10 months later. Happy ending, of course. Patient had an uneventful course, received the remainder of her chemotherapy regimen. I removed her polycyte 3 months later. The most recent MRI, Dr. Muad vividly remembers the case, and she's very sharp about it. She's now 6 years post-op, negative, no residue. So what are the lessons quickly to learn, the take-home message about rhabdomyosarcoma, about any surgery, abdominal surgery that anybody wants to do? Really, you need a specialized person to do it, and I call them, of course, oncological surgeons. You cannot come be doing a Hirschsprung disease and do one case every year or 2 years like that. That does not work. So the message to take home is that rhabdomyosarcoma is a very aggressive disease, Re-resection, yani you do not go and debulk and then say, well, I will re-resect it later on. This is completely wrong. There is no room in my mind for a re-resection. Adjuvant high-dose radiotherapy should be given, like in our case, for closed soft tissue margins, microscopically positive margin. The sciatic nerve and the obturator canal was in front of me when I removed the tumor. It is not a joke. You have to hit it hard with radiotherapy if you want to get a cure in this patient. So some would like to put clips around the resected specimens, and so always you have to think how to cure this patient. And this is our young lady now. She's very happy. She's a survivor after an abdominopelvic rhabdomyosarcoma. I don't think it was that much chemo sensitive, but surgery was done at the proper time, and the radiotherapy hit it at the proper time. You do not delay radiotherapy in those cases. And such a philosophy should apply to any tumor board meeting when we're handling kids. Thank you very much.